Remember, we had discussed previously that blunt trauma and penetrating trauma was one of the main common mechanisms of injury. In this lesson, we will discuss traumatic brain injury. This is part 3 of a 4-part lesson. A head injury is caused by a blow or jolt to the head or by penetration of the head by a bullet or other foreign object. As a result, the normal functioning of the brain is disrupted. Regardless of the severity of injury, the patient may have short-term and long-term residual effects. Traumatic brain injury can be direct or indirect. It can be primary or secondary. It results from open or closed head injury. And it depends on the speed, mass, shape, and direction of impact. Primary brain damage occurs at the time of injury and results from the physical stress, or also known as force within the tissue, caused by open or closed trauma. Also classified as mild, moderate, or severe based upon the Glasgow-Coma scale. And then we also have minor head injuries. The types of fractures associated with an open head injury are linear, depressed, open, and comminuted. Linear is a simple, clean break in which the impacted area of bone bends inward and the area around it bends outward. Depressed, the bone is pressed inward into the brain tissue to at least the thickness of the skull. Open is where the scalp is lacerated, creating a direct opening to the brain tissue. Comminuted involves fragmented bone with depression into the brain tissue. A unique fracture is a basilar skull fracture. It occurs at the base of the skull, usually extending into the anterior, middle, or posterior fossa, and results in cerebral spinal fluid leakage from the nose or ears. It has the potential for hemorrhage caused by damage to the internal carotid artery. Damage to cranial nerves include 1, 2, 7, and 8. There is also a risk for infection. Most penetrating injuries to the skull are caused by gunshot wounds and knife injuries. The degree of injury to brain tissue depends on the velocity, mass, shape, and direction of impact. High-velocity injuries produce the greatest damage to brain tissue. The patient is at risk for infection. Closed head injuries are caused by blunt trauma and lead to concussions, contusions, and lacerations of the brain. The damage to the brain may be mild, as occurs in concussive injury, or it may be more severe, causing diffuse axonal injury or widespread injury to the white matter of the brain. It's usually related to high-speed acceleration and deceleration, typically seen in motor vehicle crashes. Damage may also be found in the corpus callosum, the midbrain, the cerebellum, and the upper brainstem, depending on severity of small areas of hemorrhage, and enlargement of the lateral ventricles may be seen on a CT. With severe DAI, patient may present with immediate coma. This image depicts the normal axon from the damaged axon after DAI. Other factors that must be considered in the dynamics of head injury are the type of force and the mechanisms of injury involved. An acceleration injury is caused when external force hits the head, putting the head in motion. Deceleration is movement of the head when there is a sudden stop. Cerebrum rotates around the brainstem, leading to shearing, straining, and distortion of the brain tissue, especially the axons in the brainstem and cerebellum. Okay, secondary brain injury occurs after the initial injury. It can result from physiological, vascular, or biochemical event that involves cellular changes that cause tissue injury. Let's talk about intracranial pressure, ICP. Normal ICP is 10 to 15. If brain injury occurs, CSF is diverted to spinal subarachnoid space, or CSF absorption is increased to maintain the normal ICP. Second choice would be cerebral blood volume is then reduced. As ICP increases, cerebral perfusion decreases, leading to tissue hypoxia, a decreased serum pH level, and an increased carbon dioxide. Then cerebral vasodilation edema occurs, increasing ICP, and the cycle continues. This will then lead to the brain herniating downward by the brainstem or laterally, causing irreversible brain damage and or death. Let's discuss cerebral edema. There are two types that cause increased ICP. There's vasogenic, increase in volume of brain tissue, and cytotoxic, which occurs as a response to hypoxic insult. All hematomas are life-threatening. Why? Because they act as space-occupying lesions and are surrounded by edema. The three major types of hemorrhage following a traumatic brain injury are the epidural hematoma, resulting from arterial bleeding into the space between the dura and the inner skull, the subdural hematoma, and this results from venous bleeding into the space beneath the dura and above the arachnoid. There's acute, subacute, and chronic, and these have the highest mortality rate. And then we have intracerebral hematoma. This is an accumulation of blood within the brain tissue caused by the tearing of small arteries and veins in the subcortical white matter. So, with all this cerebral edema and increased ICP, where does the brain go? In the presence of increased ICP, the brain tissue may shift and herniate downward. Of the several types of herniation syndromes, uncal herniation is one of the most clinically significant because it is life-threatening. It is caused by a shift of one or both areas of the temporal lobe, known as the uncus. This shift creates pressure on the third cranial nerve. Late findings include dilated and non-reactive pupils, proptosis, and rapidly deteriorating level of consciousness. Central herniation is caused by a downward shift of the brainstem in diencephalon from a supraanterior lesion. It is clinically manifested by Cheyne-Stokes respirations, pinpoint and non-reactive pupils, and potential hemodynamic instability. All herniation syndromes are potentially life-threatening, and the physician must be notified immediately when they are suspected. So clinical findings of traumatic brain injury are amnesia, headache, dizziness, seizures, loss of consciousness, sleepiness or drowsiness, disorientation or confusion, scalp bruising and or tenderness, personality changes, double vision, gait changes. You want to assess for motor changes. And the severe brain injury symptoms include pupil changes, bradycardia, papilledema, high blood pressure and or widened pulse pressure, Cushing's triad, hypotension and tachycardia, which are signs and symptoms of hypovolemic shock, and nuchal rigidity, which is an indication of CSF leak. So for surgical management, you want to place ICP monitoring device, and there may possibly be a craniotomy done. Non-surgical management includes that most patients will be in the ICU. You will do ICP monitoring. You will do vital signs every 1 to 2 hours. You will manage airway and breathing. They may have mannitol boluses, Lasix, morphine, fentanyl, Ativan, Versed, Tylenol, Dilantin. You want to maintain fluid and electrolytes and nutritional status, and you'll want to watch for sensory, cognitive, and behavioral changes. This concludes part 3 of this lesson. If you have any questions related to this lesson content, contact the instructor.